Thank you, Chairperson, for the kind introduction. 안녕하세요. Hello, everyone. It's a great honor to speak here today. My name is Tomohiro Muronoi from Shimane University. Okay, so I have no COIs. To give you a clear overview of today's talk, here is a roadmap. This presentation is divided into 4 main sections. First, we will look at Japan as a global front runner in population aging and introduce Shimane Prefecture as a model of a super aged society. Next, we will explore the fragile physiological balance in elderly patients. Then I will present data from our institution. Finally, I will discuss future directions and the challenges we face. Let's begin with Japan as a global leader in aging and Shimane as a model of super aged society. First of all, Japan had the highest proportion of elderly people among major countries. To give you an idea of our longevity, there are about 81 centenarians per 100,000 population nationwide. While the global average for older adults is around 9.8%, Japan's figure is much higher, 29.1% of the population is aged 65 or older. Japan leads the world in both the 65 to 74 and the 75 and over groups. For comparison, South Korea is currently at 70.5%. However, their data suggests a rapid shift ahead. It's projected that by 2045, South Korea will surpass Japan to become the most aged society among major countries. This is why I believe today's session is particularly timely. Population aging is an inevitable global trend, and it is a great honor to discuss geriatric emergency surgery with our colleagues from ICACS. Who will soon face a demographic landscape similar to that of Japan. Now, moving on to our region, we are from Shimane Prefecture, which is geographically close to South Korea. Let me briefly introduce our hospital. It is located in northern part of Western Japan. Our prefecture stretches from east to west, has a population of about 665,000. Shimane University Hospital is located in Izumo City in the eastern part of the prefecture. Importantly, we are the only trauma center in Shimane receiving patients from across the entire region. I'd like to highlight this graph. It showed the distribution of centenarians across Japan. While the national average is around 81 per 100,000 population, Shimane reached 168, more than twice the national level. In fact, Shimane is not only the most aged region in Japan, but also one of the most aged regions in the world. Shimane has ranked first in Japan for 13 consecutive years. We practice acute care surgery, managing trauma and acute abdominal emergencies, and extending our care into the pre-hospital setting. As you know, acute care surgery comprises trauma surgery, emergency general surgery, and surgical critical care. In Japan, this field has evolved in response to unique social and healthcare demand, in parallel with development in Europe and the United States. At the Advanced Trauma Center of Shimane University Hospital, we receive approximately 2,800 ambulance transports per year, of which around 300 require surgical intervention. One of the unique features of our facility is the hybrid ER system. In general, a hybrid ER is an integrated system that combines the emergency room, CT scan, interventional radiology suite, and operating room in a single space. The key advantage of this system is that it allows severely injured patients to undergo immediate CT imaging and definitive intervention, such as surgery, without the need for transfer to another room. Now, moving on to section 2, let's address the core question. Why is emergency surgery in elderly patients so challenging? I'd like to go over the underlying theoretical background. This slide illustrates the crisis structure of geriatric surgery as a cascading domino effect. It all begins with reduced physiological reserve. On the top of that, these patients often have multiple comorbidities and tend to present with atypical symptoms, which can lead delayed or missed diagnosis. As a result, by the time they reach the operating room, risks have already accumulated. This ultimately affects their functional recovery and quality of life. So the key message is that if we do not properly assess their underlying physiology before surgery, we cannot expect to improve the final outcome. Let's start with the first element, physiological reserve in elderly patients. This reserve is inherently reduced, making them highly vulnerable to any form of stress. They cannot tolerate infection, surgery, or trauma in the same way as younger patients. This condition is what we define as frailty. So in clinical decision making, what matters is not chronological age, but the degree of frailty. This graph illustrates the narrow margin within which elderly patients thrive. Frailty and sarcopenia reduce their physiological reserve. Robust patients can recover after surgical stress, but frail patients stay much closer to the threshold of dependency. Even standard surgical stress can push them beyond that threshold. Once the threshold is crossed, returning to independent living becomes very difficult. In other words, even minor insult can lead to permanent functional decline. Next, let's consider the complex web of comorbidities. In elderly patients, chronic conditions do not simply coexist. They interact with each other. This makes clinical decision-making highly complex. For example, aggressive fluid resuscitation to treat renal failure may worsen cardiac function in fragile patients. Similarly, stopping anticoagulation for surgery increases their risk of stroke. In this way, treating one organ often comes at the expense of another. Therefore, we must treat the whole patient, not just a single disease. Another major hurdle is what I call diagnostic illusion. Elderly patients often don't show the typical signs of this disaster. They might not have a high fever or sharp pain. Instead, you might only see mild confusion or a bit of lethargy. But beneath that calm surface, life-threatening peritonitis or sepsis could be progressing rapidly. What we see is often just the tip of the iceberg. This atypical presentation is a major cause of dangerous delays in diagnosis. We also need to remember that surgery is essentially a form of controlled trauma. In a frail patient, this stress affects the entire body. This is why we often see multiple organ complications, such as a post-operative delirium, respiratory failure, and acute kidney injury. These complications frequently lead to prolonged ICU stays. In these patients, surgery is not just a local intervention, it is a systemic event. This is exactly why damage control is essential in general geriatric emergency surgery. To summarize this section, we must recognize their unique vulnerabilities, intervene as early as possible, and minimize surgical stress. In many ways, this presents the very essence of the damage control concept. Next, in section 3, I will present our institutional data and our specific strategy. We analyzed a patient age 65 and older with perforated peritonitis who underwent damage control surgery. In the initial operation, our primary goal is simple: to control contamination. We perform a resuscitative and abbreviated operation followed by often abdomen management, and then transfer the patient directly to the ICU for resuscitation. We return for bone reconstruction and definitive closure only after the patient has stabilized. For hemodynamically unstable lower gastrointestinal perforations, we adopt a staged approach. On day 1, we control contamination and transfer the patient to the ICU for resuscitation. If the patient stabilizes by the next day, we proceed with reconstruction. If the patient stabilizes by the next day, if the patient remains unstable on day 2, we limit the procedure to lavage and delay definitive surgery until day 3 or 4. Now, let me show you the result. We performed damage control surgery in 28 elderly patients with perforated peritonitis. The patient characteristics are summarized in this table, and left-sided chronic perforation was most common etiology. The median operative time for initial surgery was 105 minutes, and definitive abdominal closure was achieved in all patients within a mean 2 days. The 28-day survival rate was high at 96%, and overall is 78%. When we compare survivors and non-survivors, no significant differences observed in baseline characteristics. However, anastomotic leakage was significantly more frequently in the non-survivor group. In addition, these patients required a longer duration of mechanical ventilation. In summary, one key strength is that even if elderly patients, damage control surgery can shorten operative time and reduce initial surgical stress. leading to relatively favorable outcomes. However, a major challenge remains anastomotic leakage continues to be a significant driver of mortality. Our next step is to focus on reducing these postoperative complications. Now, let's shift our focus to trauma. We also evaluated the clinical outcome of elderly trauma patients to our center. Over a 3-year period, we admitted a total of 850 trauma patients after excluding patients who presented with cardiopulmonary arrest on arrival. We compared 257 elderly patients with 578 younger patients. This table shows the baseline characteristics of groups. One notable findings is that the elderly groups had a higher incidence of head injury and significantly longer hospital stays. When we focus on severe cases, ISS of 16 or higher, patient aged 75 and over had a higher incidence of head injury and were more severely injured on arrival. However, the key point is that despite their age and severity, there were no significant differences in mortality compared with younger patients. In patients requiring surgery for truncal trauma, outcomes were comparable to younger patients and remain favorable. So, our single center experience suggests that proactive damage control approach result in comparable survival rates in elderly patients, regardless of whether the condition is traumatic or non-traumatic. However, there is an important limitation. Hospital stays are prolonged, and most elderly patients are unable to return directly home, instead requiring transfer to long-term care facilities. Therefore, to truly improve patient outcome, we need to focus not only on survival, but also on functional recovery. This brings me to fundamental issue in geriatric surgery. Biological survival is not same as functional recovery. Saving life is only the first step. But in elderly patients, survival without independent represent a very different outcome. Our true goal should be not only survival, but the presentation of independence. Finally, I'd like to conclude by discussing future direction. How can we move beyond simply saving patients to truly preserving their lives as they need them? We still have a long way to go. To explore the challenge further, I'd like to highlight a very insightful study. This study compassed surgical outcomes using two large national databases, Japan's NCD and American NSQIP. Looking at preoperative factors, frailty increased with age in both countries. Functional dependency lies markedly after age 85 in both cohorts. One notable difference is that advanced care planning is much more prevalent in the US, highlighting important gap that needs to addressed in Japan. Post-operatively, most complications increase with age as expected. The patient a higher incidence mobility-related complication, such pressure ulcer, while incidence of post-operative derm is similar between the countries. And instead, new DNA order is much more frequent in the US, suggesting different approach to end-of-life decision-making. When we compare two profiles, several key differences emerge. One while many, especially discharge, U.S. patients are more likely to transfer care facility, while many Japanese patients return home, sometimes living alone, which may increase the risk of social isolation. Taking these international differences into account, we also need to understand regional variation within each country. All of this point to one key conclusion: we need a comprehensive geriatric assessment, named GGA. Chronological age alone is not sufficient to guide decision making. We must assess frailty, cognition, and social support in order to truly optimize patient care. Most importantly, CGA should not be a one-size-fits-all approach. It must be tailored to the specific social context of each region. In conclusion, even in elderly patients, damage control surgery can be life-saving. Early diagnosis is essential, and we should favor less invasive stage strategies such as damage control. By gaining a deep understanding of both patient-specific clinical risks and the social infrastructure of each country, we can make treatment discussion that truly improve patient well-being. Thank you for your attention. We look forward to seeing Shimane Prefecture. Thank you very much.